Hello everyone and welcome to Healthy Start's first webinar. My name is Olivia Clayton and I'm the manager of Healthy Start at the Parenting Research Centre in Melbourne. Healthy Start is a national strategy for children of parents with learning difficulties, and we're funded by the Australian Government Department of Families, Housing, Community Services and Indigenous Affairs. Our aim is to increase the service system capacity for families where a parent has learning difficulties. And one way we do this is by publishing and broadcasting evidence-based information about the support needs of parents with learning difficulties. And we are delighted about our guest today having agreed to present information about the antenatal and postnatal support service for women with learning difficulties at the WIN Clinic in Melbourne. At the end of the day, this webinar will be linked to a recording, and it will be posted on the Healthy Start website. So I encourage you to forward on the link to your colleagues or networks who might like to watch this at another time. There will also be an online discussion on the Healthy Start Practice Network related to today's webinar, commencing at its conclusion. So if you are not already a member of the online practice network, I encourage you to sign up on the Healthy Start website, which is healthystart.net.au. Let's have a little look now at who we have here today in the webinar. So quite a few Victorians with us today and less Tasmanians. That gives us a good idea of where Healthy Start needs to target its webinar promotion, I think. In regard to the types of attendees who registered for today, we have quite a few people who were working in maternal child health under that 25% nursing column, and registered nurses as well we have, and specialist clinical nurses. The other big fraction of attendees we have is family service support workers, which is also made up of some workers from Child First. And we have 23% who are classified as other, which are made up of some PADS workers, occupational therapists, and some other people in education. Now, we would really like you to email us with any suggestions that you might have for topics for future Healthy Start webinars. You can send these suggestions directly to me by replying to an email that you'll receive with the link to the recording. But without further ado, I would love to present our speaker, Cherise Smith, from the WIN Clinic at the Royal Women's Hospital. Cherise has been a registered nurse since 1987 and midwife since 1990. She commenced working as the coordinator of the WIN Clinic when it was funded by the Department of Human Services as a pilot project in 2002. She was instrumental in having the WIN Clinic integrated into the maternity care program at the Women's Hospital at the end of the pilot. And Cherise currently has the dual role of coordinator and of direct service to pregnant women, providing antenatal and postnatal care at the WIN Clinic. In cases where there are high-risk pregnancies, she works closely with the obstetrics team. Now, while I'm handing over control of the webinar to Cherise, we have a quick live poll for you to respond to now. The question is, have you heard of the WIN Clinic before this webinar? In the go-to webinar screen that you have, you should see a poll where you can respond. Okay, just a few seconds for people to click on their response, and then we'll hear from our presenter. Great, so almost all of you have voted. I'm going to close the poll now. Thank you for responding. So 81% of you have never heard of the WIN Clinic before today, and 13 of you have, while 6% have just heard a little bit about it, but don't know much and hope to know more. Now you'll also see in your webinar control panel there a box where you can post questions. So as live attendees, you have the opportunity to ask questions of our presenter. I encourage you to submit a question here anytime, and this presentation will go for approximately 30 minutes, and in the last 15 minutes I will pick out some of the questions you have submitted for Cherise to respond to. Now I'm going to hand over the presentation to Cherise, and over to you.
For a minute. Full screen there. So I'm just looking to view.
That's fine like that, Cherise.
But I can't find the full screen. Is that a... Yep, that's fine.
We can see
that. Okay, thanks. Thank you, Olivia, for your introduction. As Olivia mentioned, I am the midwife coordinator for the Women's Individual Needs Clinic at the Women's Hospital Melbourne, which is also often referred to as the WIN Clinic. Now, it's great having this opportunity to be able to present our clinic, as 80% of you have not heard of us. So now you will have. Now I'll just move on to the next slide. So today's presentation will discuss who we are, what do we do and how do we do it, what we have found, and what does this mean for you. The Women's Individual Needs Clinic is a pregnancy clinic for women with an intellectual disability, learning difficulty, acquired brain injury, physical disability or sensory impairment. The WIN Clinic has been operational since 2003. Prior to commencement of this clinic, the existing service model had been identified as inadequate in addressing the particular social situations and learning needs of women with mild intellectual disability preparing for childbirth and parenthood. Concurrently, some research came out by David O'Connell, Rachel Mays and Professor Gwyneth Llewellyn from the University of Sydney, which supported the need for better antenatal services for women with special needs to improve the outcome of these pregnancies and subsequently infant well-being. The WIN Clinic was established to meet these needs. The WIN Clinic cares for approximately 30 to 35 women per year. Data has been collected on 266 women supported by the WIN Clinic from 2003 to June 2011. The information today is based, I guess, on limited numbers when looking at getting outcomes and results. However, having said that, we are the only antenatal clinic that, which we are aware, provides care and support specifically dedicated for women with disability who are pregnant. So this is our finding. The women have been divided up into various groups on these slides and combinations, and due to the lack of documentation re-diagnosis of an intellectual disability, as often the women will reply to us when asked, you know, have you been diagnosed with an intellectual disability? They'll say they were tested when they're at school and they don't know where the report is, or they don't know who actually diagnosed them, or were just told by their parents that they had a learning difficulty or knew and identified that they had difficulty with schoolwork. So we are often reliant upon documentation of professionals working with the women or the women themselves and identifying that they have an intellectual disability or learning difficulty. As a diagnosis, it is unclear these women tend to be referred, like whether they've got a learning difficulty or an intellectual disability. So we tend to generally group them as having a developmental delay or cognitive impairment. Over the last 3 years, 56% of the WIN patients have been supported, had developmental delay Prior to this, it was like 76 of our patients. The decrease in percentage has been due to the fact that the WIN clinic's now taking a broader range of disabilities. Initially, we only accepted women with a developmental delay. However, we now accept women with sensory and physical impairments as well. Physical impairment being the next most common of our patients, followed by patients with sensory impairments. So in this slide here that I've got up now, this slide basically looks at the physical disabilities and sensory impairments of the women that we have through our clinic. Some of the type of physical disabilities and sensory impairments. I'll leave that up for a second. The type of disabilities sorry, I'll just go back to that previous slide, shows you the variety of physical and sensory impairments. Hearing impairment is the most common sensory impairment, and cerebral palsy is the most common physical impairment that we care for through our clinic. Now, we know that women with disabilities face disadvantages, and these disadvantages include things as noted on the screen: poverty, unemployment, substandard housing, high stress levels, a history of maltreatment, depression, poor self-esteem, a lack of positive parenting role models, limited learning opportunities, limited informal supports, limited formal supports, and poor health. The women have often had negative learning experiences which has affected their self-esteem and, also been bullied at school. They may be living on a disability pension and so therefore have substandard housing, often live in government housing or even boarding houses where it's impractical to take a baby home to. And they've often suffered maltreatment by family members, also been sexually abused, and they're quite a vulnerable group of people. They tend to not have a lot of even informal supports where they can rely on getting good advice, reparenting, and find it difficult to sometimes access information that's appropriate for their style of learning on parenting. A lot of things are very wordy and too involved, too complicated for them if they even want to try and self-search information on parenting. The information quite often isn't there or easily accessible for them. They've also often been told that they can't do things, which once again is affecting their self-esteem, and this we know isn't always the case. They feel they can't do things, but with the right encouragement and the right care and the right supports put in place, they quite often very well can do things. So one of the things that we've noted there is mentioned, just going over to the next slide, is that the women quite often have poor health. This slide is about a list of some of the various syndromes and health problems women have had when presenting to our antenatal clinic. Now, as you can see, they're quite a varied lot of maternal conditions. So these are conditions that the women actually have, their syndromes and other health problems that they have are impacting on their health, which may or may not be significant in pregnancy, but often does require specialist medical care through maternal fetal medicine doctors. So this slide, and just moving over to just another continued list, shows you the complexity of the maternal conditions can have on a pregnancy, and the reason, why it is important that these women are seeing the right medical staff and receiving high quality care. The most common maternal condition that we have is women having is epilepsy. Now, whether that's also part of a syndrome, but a lot of the women we have do suffer from epilepsy. Now, unfortunately for these women, child protection involvement is at times a reality for women, particularly with disabilities, having children. It's important to remember that, as I say here, that there's such disadvantages that families face is often associated with chaotic living circumstances that can bring families to the attention of the child protection system. And the other we have there is Australian research who showed that parents with intellectual disability are disproportionately presented as child protection services and care proceedings. And the reasons why this may be is assumptions of the people working with them, high levels of disadvantages faced by the families, and the gaps in effective services, support and resources for these women. The research has found that has identified features of service system that may weaken rather than strengthen the parent's belief. So some of the assumptions that are made is that believing that a parent does not have the capacity to learn and can result in practitioners giving them fewer opportunities to learn. For example, if you never teach a parent how to take a child's temperature because you think that they can't be taught how to take a child's temperature, then how can you expect them to ever do that? So we're looking at that they can learn to do things, or should be given the chance to learn to do things, because it's unfair to say that they're not doing certain parent craft skills for their children if they've never been given the opportunity to learn how to do that. And our clinic focuses on giving women that opportunity. Sorry, that's assumptions. So the assumptions of practitioners is quite important. People caring for women with disabilities need to be thinking of these women in the way of what can they do, what are their difficulties, and how can we help them overcome these difficulties. And so rather than focusing on the disability, focus on the disadvantage that they face. Look at their whole environment, look at their home situation, what do they need help with, because unless you can help in that area, you can't just send someone home with a baby and expect everything to go well. It's not just about doing antenatal care, coming into hospital for a couple of days and going home. There's a whole lot more that needs to be looked at with this particular group of women. So what do we do as a clinic, as the Women Clinic? What do we do? We work with women with disabilities who are pregnant to provide the best outcomes for mother and baby. So how do we do this? We provide a dedicated midwife and social worker with expertise in disability. We have a holistic approach, as I mentioned, working on and providing a model of supportive care in contextual situations. We simplify accessibility to the midwife and the social worker. The patients can call us directly. I have a mobile that they can contact me on. I have a landline that's voicemail that they can ring up and leave a message on, but once again, only I listen to. It's not like they're going to ring the hospital and think they're leaving the message, and it could be something quite private to them, and who else is going to be listening to it. They know that it's me that will be the person that will listen to it if they ring my number, and if they ring the social worker's number, also they know that they're ringing to speak to her. I find the mobile phone works really well with these women. They often have, it's especially with the younger clientele, texting is their mode of communication, and so quite often if you ring they won't answer the telephone, but if you text them they'll read your text and quite often respond back to you. Like I will, for example, ring the patient to remind her that she has an appointment tomorrow, or ask her if she's planning to come to her appointment tomorrow, and quite often I've rung first and I've got no response, so I've then texted the woman and she's responded to me via text, or then even rang me back because she's happy to talk about that further. She even knows what I'm actually ringing her about. So they tend to screen their calls quite a lot. So I think for us, the mobile phone is a really valuable tool that we have with the women. Also, like, it's not like I'm just at my desk all the time, so I'm carrying my mobile phone with me. It makes me much more accessible. They know when they ring the hospital, if they've got a question to ask me, they can ring, and they know they're going to speak to me, and that they will ring and call me directly and ask me a question. I make their appointments for them, so with them, so they don't have to go and basically queue up in the mainstream, make appointments, communicate, try and communicate and understand what the mainstream system is. It's simplifying the accessibility to the midwife and the social worker. Continuity of care, like same midwife, same social worker, aids client-professional relationship, builds trust, rapport and familiarity between family and health carer. So we have more frequent appointments. We see the women every 3 weeks to monitor complex situations and implement timely actions, whether that be social worker circumstances or in regards to their health during the pregnancy and the actual pregnancy itself and growing fetus or baby. We allow 1 hour for the appointments to allow time for discussion and explain pregnancy issues or concerns. I find when I see the women, you know, I'm here as the midwife, and then there's the social worker who's looking at all their psychosocial aspect, but the women, you know, sometimes have difficulty just focusing on the medical side, like they've come in for an antenatal check, a baby pregnancy check. But if there's been something happened that day, earlier in that day, that's really impacting on their life, they find it very hard to stay focused on the fact that we're here for an antenatal check, and they want to tell you about everything that's happened. And you know, part of the holistic care is listening to the woman as well, and giving her time to tell you things that are mostly important to her, and then relaying that, if appropriate, onto the social worker with her permission, or asking her if she would like to see the social worker that day so that they can go through things more thoroughly. And also, like, it gives us time to actually talk about the pregnancy, what's happening in the pregnancy. The women quite often have lots of questions about their pregnancy and what's happening to them, and it does give us time to sit and explain to the woman in a way that she can understand it. And I think that having that hour appointment and seeing the women frequently, you do build up that rapport, you get to know them, they get to know you, they become quite familiar with you. They're more likely to tell you and ask you questions. Sometimes they don't ask questions going through the mainstream system because they're embarrassed to ask the question. They might look stupid, and they've very much learnt through their life experience of schooling is that, you know, sometimes it's better not to ask and you just pretend that you look like you know. Whereas I feel like once we build up that rapport and that relationship, they'll say to me, oh, I didn't get what you just said then, what did that mean? And so I'm able to reword the information that I've given them. Also, if the women have doctor's visits, if they are high-risk medical cases and they need to have that specialist medical care, I will go into the appointments where possible with the women, sit with them, listen, talk to the doctor with them, so that once we come out, I've also heard what the doctor's told them. I can prompt them to ask questions that I know that they want to be reminded to ask in the appointment, and I have time after the appointment to sit with the woman and then just explain to her in a way that, once again, that she can comprehend that what the doctor has just told her, and answer any questions that may have just happened whilst in seeing the doctor. We encourage attendance to appointments and assist to overcome obstacles preventing attendance. So basically, if the woman isn't coming for her appointments, we follow up, we ring them, and we try and work out what's stopping them from coming. We want women to come to their appointments so that the baby in the pregnancy is getting, you know, good antenatal care, so that problems can be picked up early. So if it's transport or other reasons, once again, that's where the social worker can also help in overcoming the disadvantages or the difficulties. And we empower the women to be involved as well in their own decision making, involve the women with in meetings, in support persons in case planning meetings, best interest meetings, and we use a strength-based approach built on what they can do and help with appropriate supports to assist with the difficulties. So it's a matter of identifying the difficulties and helping them be linked into community supports that are going to be able to supply them with those long-term supports. We also have a heavy emphasis on demonstrations and practical application. Research, once again, tells us that teaching and learning skills in the setting in which the skills are most needed is often in the family home. So teaching someone how to do things in a hospital can sometimes be difficult for the woman to transfer that information from hospital to home. So I actually go out, I see the women antenatally, I do a one-on-one childbirth education with them, or we call it parenting information, and I sit down with the women. I look at what clothes they've already bought for the baby or things that they have for the baby. Like sometimes the women will say, oh, I've been given all these clothes, and I sit and I go through all the clothes. They might be size 1s and size 2s. So I sit down and I actually get out all the triple O's or the 4 O's, and we put it all in a pile, and we say, well, this is all the stuff that the baby's going to need now. So the rest we can all put back in a bag. But this stuff here, this pile is the stuff that will fit the baby when you first come home. And then if it looks like they haven't got enough wraps or they haven't got enough, funny grow suits or whatever, I'll suggest that you may need to go out and get some more of these things. You may need to get some more wraps. You may need to get a coat for the baby or whatever is appropriate. So doing that that's one of the good things about going out to their home, because you actually can go out and you can have a look at the all the other equipment that they've got, and whether they have actually got a pram and whether they have actually got a cot and where they plan to sleep the baby, and you can show them how to make up the cot, like that, and where is the cot going to be in the house, and generally making sure the setup is safe. We also do like a baby demonstration, like a bathing demonstration at home with the doll in the bath. So I actually set the bath up and I get the doll and we bath the doll, and where are you going to be doing this at home, and looking at where is the most safest and practical place to do this at home, so that when they go home from hospital they've already got all those things sorted, and we've got a fairly good idea that they're well prepared with equipment and as much knowledge as we can give them to safely care for their baby. And that's one of the positives of this program, is having the ability to do the outreach. We also continue to do outreach up to 6 weeks postnatal, so I continue to go and see the women for 6 weeks postnatally. And with that, sometimes I do a dual visit with the maternal child health nurse, the enhanced home visiting midwife, or the enhanced home visiting midwife or maternal child health nurse, and I will email each other, liaise with each other in regards to what information we're giving, to make sure we're giving consistent information. And it's just an extra person going out to see them. We still have all those other services coming that would normally be there, but it's just an added support. And I'm basically helping the transition from hospital to home. I'm basically filling in that gap until the community services like maternal and child health nurse and other parenting services are well linked in with the woman, and they've started to build up a bit of rapport. By the time I'm starting to step out at 6 weeks, the aim is that we will have got the woman linked in with more long-term services, and so that staying involved up to 6 weeks is helping that transition from hospital to home and to long-term services. Now, good communication between all professionals is paramount, which is another important role that we play in this clinic. So we've got the women's clinic, and we've got the patient and the family that we're dealing with, but on this screen you can see that all the other services that could be involved with this woman. There's other hospitals, like we've had women that have had eating disorders and have been admitted for eating disorders at other hospitals. We've had women with multiple sclerosis who have been admitted to rehab centres if they've had a relapse of their multiple sclerosis. Women with other neurological disorders that may also be being cared for from another hospital. So it's important that we have good communication with the doctors that they see, the neurologists and eating disorder doctors, or other hospitals that they're involved with. They also see like the genetics, they may be seeing someone from the genetics clinic, they may be seeing other specialist clinics within the hospital. It's also occupational therapy, physiotherapy, even dentists and other diagnostic services that we're communicating with. Enhanced home visiting midwives, they're local doctors. Local doctor can be a really important person, especially if they've got someone that they have been seeing for a long time, to keep them informed as well. And there's been times, like say for people, one woman had quite a severe intellectual disability, was ringing the ambulance service all the time, and they got to a point where they really weren't attending to her, so we rang up and we did sort of say to them, ended up writing a letter saying that this woman was known to our service and that she had an intellectual disability and that she was nearly full term, and if she did happen to ring up and say that she was in labour, it was in paramount to her safety that they did attend her calls, and that if there was any query, could they please bring her to our hospital, as we were well informed of this woman and knew a lot about her. So that sort of also helps the ambulance service as well. And with another couple where both were deaf, we did the same thing. If they rang up, they were hearing impaired. Both couples don't lip read, and so communication could have been difficult, and that they were relying on neighbours to call the ambulance, etc., etc. So, and even dealing with the community pharmacist and getting tablets made up in dose sets and things like that, making sure that there's good communication from us to them. We've had people that have had medical guardians through VCAT, and we've had to liaise with the medical guardian and the family as well, and especially becomes complicated when caesareans and all that sort of thing needs to be implemented, and parents wanting sterilisation and all having to go through the medical guardian and what type of contraception is appropriate for that woman. So as you can see, if some women will use multiple hospitals. They won't just come to us. So if we know that they've been attending an emergency department at some hospitals, we will make contact with the other hospital and tell them, that they're with our clinic, and if there's any information required, they can contact us, and to just be aware that the woman may just turn up and be in labour at some stage at their hospital. And we're, at times, child first referrals and child protection referrals and referrals to early parenting centres, and also, of course, liaising with the disability workers and case managers that are involved with these women. So sometimes I've been to some case planning meetings and there's been like 10 workers at the meeting. So it can be very complex and very involved coordinating the care. We're not the case managers, but we're just coordinating the care for the woman while she's attending our hospital and receiving care within our hospital, keeping everybody informed as to what is actually happening with that woman. So another thing that we've found throughout our clinic is that the women generally are younger than the average general population. However, looking at that slide, as you can see, most of the women are well into their 20s having a baby. We do have women aging from as low as 15 through to 45, but on average, the average woman probably would be moving on to the child protection, what we've sort of found figures coming through our clinic. As a woman we looked at like March 03 to 09, and then we looked at, and the reason that we did that is in March 2007 we saw the introduction and phasing in of Child First. It's a DHS initiative, and by 2009 Child First was operating throughout Victoria. Child First prioritises services on the basis of need and links families into community supports. Notification to child protection is still required if there is deemed as any significant concerns for either welfare or safety of children as described in the Children's, Youth and Families Act 2005. So here this slide just shows if people generally with a disability, so we've not only got women with a developmental delay, but we've got women with developmental delay, physical or sensory disability. So prior to the introduction of Child First, the women with a disability that was presenting to the WIN clinic, now I just want to stress that not necessarily these figures are us doing notifications to child protection. This is just notifications to child protection in general. These notifications can come through various agencies or even just people that they know, and sometimes people that they know tend to notify just even for very minor reasons. But prior to Child First, 42% of women with a disability had a notification to child protection, and of those 29% of families the baby was not in the care of the biological mother at the end of the neonatal period, so that being at 6 weeks of age. But after the introduction of Child First, we found that there were fewer notifications to child protection because the child protection were the ones that were able to implement the support systems prior to Child First. Now there's Child First, so we're able to get supports in place without having to do notifications. And of those women now, only there's 21% fewer removals of babies to women with disabilities that we see coming through the clinic. For women with a developmental delay, prior to Child First, 50% of the women were, there was a notification done to Child Protection, and after Child First, 39% of women had notifications to Child Protection, and the percentage not in the care was 31% at the end. So of the women that had a notification, 31% of the children were removed from the mother's care within the first 6 weeks after birth. So what we sort of found here is that there were fewer referrals, but of the referrals that we're doing, there is actually quite a number of much more significant concerns. So the number of babies not in the care of a mother with a developmental delay in general, so whether notification was done or not, is 11%. So the chance of having a child removed that's at risk is 11% with having a developmental delay, which looks sort of in real figures through our clinic, it's probably 1 or 2 babies a year. Now this is just some of the pictures or graphs on the commencement of birthing process at the Women's Hospital. So 65% of women went into labour spontaneously as opposed to 39% of our women, and we had a lot more inductions, and elective caesareans were about the same. So more women were induced, less women went into spontaneous labour, and that's sometimes to do with the keeping in mind we've got much more complex medical issues with these women, maternal conditions. Now also, just wanted to mention the research that was done, antenatal care and birth outcomes of women with learning difficulties by David McConnell, Rachel Mayers and Professor Gwyneth Llewellyn. They looked at 57 women with an ID and found that women with a learning difficulty were more likely to have low birth weight babies, deliver less than 37 weeks, preeclampsia, and induction of labour. We looked at 62 women at around a similar time, and I think that sort of research was done about 2002. We looked at the similar time of 2005, and we looked at, included all our women, which probably the majority of those women were women with a developmental delay, and we actually had very similar findings. Our findings through our clinic agreed with what was found through that study. And, you know, as that study's conclusion said, further research is needed to understand the reason for the adverse findings of this study and identify potentially changeable factors contributing to adverse pregnancies and birth outcomes for women with ID. So, you know, obviously we haven't done that, but it's interesting, yeah, that we're dealing with the same sort of type of situations, and so therefore we're more likely to have women that need induction of labour. And once again, I think that's a lot to do with their health and general medical conditions and living conditions and general health. Looking at the delivery outcomes, in 2010 we had a 32% caesarean rate. That's me telling me that I need to hurry up. We had 32% caesarean rate for the general population in the hospital, and the wing clinic had a 51% caesarean rate, or 49% normal vaginal delivery rate. And once again, we've got women with really complex medical problems. We know that these women are having premature babies, low birth weight babies, and more suffering preeclampsia more often as a higher population density there. More of them have got complex pregnancies, and some of the women we've actually done elective caesareans on as a result of the woman not even having, you know, that abstract thinking thing, not being able to see the baby growing in their stomach and being absolutely terrified of labour. It sometimes has been deemed more I guess beneficial for the woman overall to have a caesarean as opposed to go through labour and birth, and that's been quite terrifying for them. So really, what does this mean for you, all this information? Well, you can refer to us. We're not limited by postcode or boundaries if you feel someone would benefit from our specialised care. The outreach we've had to pull back on that a little bit and say that if you live out of 20 to 30 kilometres of our zone, then we can't really see you, because otherwise I might be travelling to the country and seeing one person for a whole day, and that would be very impractical. So we do have that specialist care, but and I'm happy to see you, happy to be involved with your care, or the care of the women, but limited by practicality of distance. The process of referral is that you can get a referral from the local doctor and fax it through to our access centre, or contact myself or the social worker directly, and I've got my numbers on the last screen, which is the next screen. And subject to availability, we can provide presentations like this and give education to community agencies who provide service to women with disabilities who are pregnant. And so this is the last slide, and these are our contact details. So any referral from local doctors can be faxed through to the Access Centre and will hopefully appropriately be forwarded on to myself, or there's my contact name details of Cherise Smith, the clinic coordinator, and the social work department, and as I say, there's assigned specialist social worker. Thank you. Back to you, Olivia.
Thank you so much, Cherise, for such an engaging and thorough look at your model. I want to now take a Q&A session for what I think we have left of the time, which is only a couple of minutes. Now, if you would like, you can post your question in the GoToWebinar control panel that you should have on your screen. Now, we'll also be continuing discussion about this webinar on the Healthy Start Online Practice Network. When we've uploaded the recording there, you'll be sent an email with a link to that discussion. And if you're not a member of the Online Practice Network already, you can do that easily throughout our website. Now I'm just having a little look through the questions now. Just got a technical question. Thank you very much, because this could be applicable to everybody. Is someone asking, how can I print the slides? So this presentation can't be printed from your screen now. It's obviously a live webinar. However, we will make those slides available as well as the recording on the Healthy Start website. Now, another question here is, can a referral be made by child first, as often clients are not linked with a GP? So I'll let you take that one, Cherise.
We take referrals from anybody, even if the patient wants to self-refer. We have had women self-refer. We've had women that have been through our clinic once and want to come back again, and they can ring me and contact me directly and get further information on what needs to be done to specifically come to the WIN clinic. And sometimes I just make sure that the Access Centre are aware that there's going to be a referral for a certain person come through. So feel free to contact me at any time. Anybody can basically refer to us.
And contact you directly on the number that's on the screen now?
Yes, yeah, on the mobile number or the landline number is fine.
Okay, well, we'll make sure we put up your mobile number on the website. Now, we've got another question, just a bit more information about who's in the team that you have there. Are there others apart from yourself? It's a part-time position that I hold. I work 3 days a week, and Naomi does 2 days one week and 3 days the next week. She's the WIN social worker. So there's myself and the social worker, and then we liaise with the other departments in the hospital, but mainly just the two of us. And that's why I guess we're limited at this stage to see 30 to 35 women a year, because there is only us, and we both do basically only work part-time. Well, that's a shame, Cherise, because we've got, I'm going to name you Marg, from New South Wales, hoping that she could actually send all of the mums that she sees at Intellectual Disability Rights Service through to you when they're going through their pregnancies. But perhaps one day.
Well, we're more than happy for other people to open up. We're more than happy for other people to start some their clinics off in their own major tertiary hospitals. We'd be happy to have a few more WIN clinics around the place.
Yeah, that would be fantastic. All right, well, I'm going to finish off today by just saying thank you very much for your time, Cherise. So great to get such a good insight into the types of clients that you see there and the inner workings of WIN. Now, again, if you'd like to ask any more questions of Cherise or have a bit of a discussion with us on the online practice network, it's healthystart.net.au, and we'll also post some information about upcoming webinars on that website. So thank you everyone for your time today, and particularly Cherise for presenting, and I hope to speak to you online soon.
Okay, thanks.
Thanks, Cherise. Bye.
Bye.